Welcome back to Mayo Clinic Radio. I'm Dr. Tom Shives.
And I'm Tracy McRae.
The Centers for Disease Control and Prevention reports that every year about 14 million Americans become infected with the human papilloma virus, or HPV. And most of those that are infected are teenagers or young adults.
The CDC also reports that cancers caused by HPV are diagnosed in an estimated 18,000 women and 9,000 men each year.
And a vaccine was actually introduced in 2006 to help prevent HPV-related cancers. But a decade later, the HPV vaccine continues to be the most underutilized childhood immunization, and especially so for boys.
Here to discuss the HPV vaccine is Mayo Clinic expert Dr. Gregory Poland. Welcome back to the program, Dr. Poland.
Thank you, Tracy and Tom. Good to be here.
Greg, nice to have you. I mean, Jimmy Kimmel to hear you're moving up.
We're happy to have you here, but especially to talk about this important topic, because the amount of HPV that is out there and the way that people think about it, it's an important thing to have a conversation about.
You're so right. One of the problems that we've had, as Tom indicated, over a decade, and we're still in low double-digit immunization coverage levels, is the fact that this is a sexually transmitted disease. And what it transmits is not only the virus, but the virus that causes cancer. This virus causes over 7 different cancers. The problem is, since we're giving it to young children, parents interpret this as, quote, a sexually transmitted disease. My child isn't going to get an STD, and there's no reason to get it. That's one major problem. The other major problem is the cost. It's a pretty expensive vaccine.
Now, you said 7 different cancers. The one, of course, we're all familiar with is cancer of the cervix,
Exactly.
but in women. But what are the other ones, and what does it cause in men?
Yeah, vaginal cancer, other epithelial cancers, penile cancer, anal cancer, most of the oral pharyngeal cancer that's seen. So this is a big issue.
So cancer of the tonsil and the throat.
Yes.
Oropharyngeal.
Yes.
Oh my gosh, really?
Yes. And that's the cancer part of it. The other side of it is the genital warts that this causes. And we have a clinic here at Mayo Clinic, as I think all tertiary and quaternary care clinics have, where we have, unfortunately, young women whose throats are lined with thousands of these warts that literally occludes their breathing. And they have to go in with a laser and laser these off one at a time, and they will do so for the duration of these young girls' lives.
Really?
Yes.
So, but do they can it be cured ultimately?
It can't be cured, but they can try to keep it in check so that they can breathe.
Never heard of that.
Yeah.
Have you ever heard of that?
And
I
most
had
people
not heard
haven't.
of that, no. I
So-
knew that you know what, I have to say the message that I have gotten, I used to be a young woman, was just that, everybody gets HPV and that's just kind of the way that it goes.
So that's not quite correct. What I would say is everybody who has sexual exposure runs a strong risk of exposure to the HPV virus. The majority of women will resolve that infection with hopefully no sequelae, but some don't, and these are the ones that develop cancers. Initial policy was that we would immunize young women, and it very quickly became apparent, well, the boys are transmitting it and spreading it to the women and to other boys, and so we really needed a nationwide policy. I have these discussions all the time with parents and with patients, and here's how I prefer to position this. This is an anti-cancer vaccine. If you want to protect your child from a virus they're almost certainly going to be exposed to, and which runs a high risk of developing a cancer, this is a safe and effective vaccine.
And so the fact that you have to give this vaccine before the person becomes sexually active, that's why 11 and 12-year-olds, it's hard for parents to wrap their heads around the fact that someday their beautiful little boy and girl are going to be in a sexual relationship.
Yeah, well, that's of course not true for our children, but other people. And
That's what they all
And that's
say.
what the thinking is. And unfortunately, and it is a reflection of our culture, the average age, I don't like the term, it's what the term that's used of sexual debut in girls is now down to 13.
No.
And so this is a vaccine
You
that we
girls.
start giving starting at age 9. And the interesting thing, and I plead with parents to listen to this, the younger the child in that 9 to 13-year-old age group, the younger they are, rather than waiting till they're in their 20s, when they get the vaccine, the better the response. They are far better protected by getting the vaccine younger, even though they might not need that protection till they're a little bit older.
Usually, you mentioned that it's a little bit expensive. There's a social stigma out there. Parents don't want to think their kids are ever going to have a sexual encounter. But also, doesn't it require 3 doses?
You're very right, Tom, and that's, again, something that's a little bit of an inhibitor to getting the full series. It requires 3 doses over 6 months with the Accountable Care Act and Vaccines for Children Act. It is covered in young children, so that shouldn't be a factor that inhibits getting it. But later this month, the Centers for Disease Control is in fact evaluating a potential change in policy where girls before the age of 15 might be able to get only 2 doses rather than 3 doses.
Wow, that'd be good, huh?
It would be a great advance, I think, in improving immunization rates.
And for boys too?
We don't know yet. More research needs to be done there, but I would hope so.
Well, mine just got his 3rd dose last Wednesday, so let's keep that information under wraps.
That's right.
I want to go back to the part where the parents, well-meaning as they may be, just think, this is not my kid. This is not. Is there any at all socioeconomic, regional, any way that you see HPV in some populations more than others at all?
Well, what I would say is the indirect factors that lead to increased sexual activity and sexual exposure are the factors that increase HPV infection. So we tend to see it more often in lower socioeconomic groups and ethnic groups, but it's in everybody. I mean, as soon as I say that, I want to say it's everybody. So it's really, really important that people get this vaccine. It is meant to be universally applied.
And it's effective, 100%
Absolutely.
effective as
Well,
far as
it's as
hard to
close
know.
it's as close to 100% as you can get, both for the prevention of cancer and the prevention of these genital warts. And again, for genital warts, there is no treatment. There's only prevention.
And it's a virus.
It's a virus,
Yeah,
yes. And it's
so-
a virus that has multiple subtypes. So the first vaccine we had protected against 2. The next one was 4. And the most recent vaccine protects against 9 different types of that virus.
Well, it's sort of interesting that you actually have a vaccine against a virus, particularly one that's so widespread.
Yes.
So the age at which your children should get the vaccine, you mentioned that the average American female has her sexual debut. I thought that's a very interesting way to put it.
I
At
don't
age
like it at all.
13, you don't like it?
I have a 14-year-old. I don't like it at all.
Yeah.
So you should get the vaccine. Your kids should get vaccinated between 9 and 12.
Well, what we know is that between 9 and 15, boys and girls have the best immune response. They still respond well between 15 and up to age 26. After age 26, we're immunologically old in terms of this vaccine, and women don't respond very well to it. So we really want to get this vaccine and that protection, that immunity, as early as possible.
So the final message that you have for parents when it comes to whether or not their child should receive the HPV vaccine?
I think number 1, there is no evidence that getting this vaccine is going to increase promiscuity. That's been a fear. There is no evidence for that. Number 2, this virus is ubiquitous. It is everywhere. They are going to get exposed to it in today's world. Number 3, this is a safe and effective anti-cancer vaccine.
HPV vaccine with infectious disease specialist and immunization expert, Dr. Greg Poland. Time for a short break, but when we come back,
We're going to turn our attention to another hot topic, the Zika virus. That's the last time you were here. We were talking about
Yes,
Zika.
ma'am.
You're listening to Mayo Clinic Radio on the Mayo Clinic News Network.
Welcome back to Mayo Clinic Radio. I'm Dr. Tom Shives.
And I'm Tracy McCrae.
We are back talking with immunization expert Dr. Greg Poland. So, Dr. Poland, we'll turn our attention now to another topic that's been in the news recently, the Zika virus. Now, Hurricane Matthew, it's come and it's gone, but standing water left behind has some along the East Coast worried about the possibility of more mosquitoes, and I guess that would mean more cases of the Zika virus.
Absolutely, Tom. I'm concerned about that too. Public health authorities are concerned. We have warm temperatures down there. We've got lots of standing water. I just left Florida 2 days ago, and there is water everywhere.
Really?
And this is going to be a prime breeding ground for these mosquitoes.
They have mosquitoes 365 days a year down there?
They do.
Oh, there's a benefit of living in Minnesota.
But I'll tell you what we tend to think that way, but the southern to almost middle part of the state of Minnesota has the particular species of mosquito that can transmit this virus. So some 30 states in the union are at risk for this.
Now, the last time that you were here, it was before the Olympics. We were
Yes.
talking about Mayo Clinic working on a Zika vaccine.
Yes.
So first of all, let's talk about the Olympics. What ended up happening with Zika and the Olympics?
You know, it's a very hard thing to trace, but there does not seem to be widespread international spread of that virus as a result of the Olympics.
Good.
So that was a good thing. I think that control efforts seem to help there.
So tell us about this disease. If you get bitten by a mosquito that's carrying the Zika virus, what happens? And I guess there's no treatment, right?
You're very right. So what happens is the mosquito feeds on you and then injects the virus, regurgitates it literally into you. That virus multiplies. 80% of the time, people have no symptoms or little in the way of any symptoms. 20% of the time, they develop complications and symptoms. And the things that we're most concerned about are when pregnant women get infected. It can cause terrible congenital malformations, the microcephaly or small head, developmental delay, a host of other things in the unborn baby. And for older individuals that get infected, the risk of Guillain-Barré, a paralysis that can occur as a result.
So, but otherwise, for most people, if they do get sick from the virus, it's like the flu, or what is it like?
It's pretty mild. Now, there are exceptions. There was a case out in Utah where a man died as a result of it, and we're not particularly sure why. He had extraordinarily high levels of virus in his blood. Again, we don't know why. That's not the typical picture that's seen clinically. But, and here's the big part, this virus has only been studied by modern medical and scientific methods since the end of last year.
Mm-hmm.
We know very little overall about this virus, and while we're studying it, the virus changes, has mutations, is learning to adapt to human populations. And worrisome for the U.S. is the fact that we are a virgin population in terms of this virus. We have no herd or population immunity to it, and this tends to increase the risk that the virus will multiply, mutate, change, and increase its ability to transmit from person to person.
Did the man in Utah get it because he went to the Olympics or because he was in Miami, where did he catch it?
He had traveled, and even more surprising is some of his family who took care of him, for example, wiped his tears and kissed him on the cheek and all, got infected too.
Wow.
So you can definitively diagnose this.
Yes.
If someone is ill, you can say, yes, for sure you have, based on a
Yes.
blood test.
Yes.
So what do you tell a young woman who is pregnant and gets the Zika virus?
So right now, the recommendation is that if you're planning a family or you're pregnant, to avoid any non-essential travel to Zika endemic areas, and that now includes the south part of Florida.
Really?
And then if they have had any exposure, either from a male or from being in an area like that, we would test them. And there's a somewhat complicated algorithm by which we would test them.
One of the things I remember from our conversations last summer was that that virus will live in a man longer than it does in a woman. So even if you come back from having traveled and you're not sick, you can have symptoms show up 6 weeks later.
We're now recommending that they delay initiating a family when they've been in an area like that for 6 months.
Wow.
See, the male is so much more of a hospitable environment. Yeah. So no treatment. symptoms are sort of flu-like. You can definitively make the diagnosis. Now, for example, for the flu, when we've talked before, if you make the diagnosis of influenza early, there are some antiviral medications that'll shorten the disease by a full 24 hours.
Right.
How about the Zika?
And prevent complications.
And
but
prevent complications.
We have no treatment for Zika virus. We have no ways of preventing it other than preventing the bite. Only the female mosquito bites. So in the little back and forth we're having about males and females, it's only the female mosquito. And she bites predominantly during the day, unlike the mosquitoes we're predominantly used to, which are dusk and nighttime biters.
You know, I was thinking it's been 2 years this time of year since the Ebola freak out happened in this country.
Oh.
And now we have the Zika virus moving throughout the country, which it seems would be something that people should legitimately be concerned about. The risk of getting the Ebola virus was a lot greater. Am I reading that correctly?
Well, no, the risk of Ebola for somebody living here in the U.S. and not traveling to those areas was essentially zero.
Right.
Maybe a healthcare
But people were
worker.
terrified.
Yes. But, you know, what we have now, for a variety of reasons we can talk about, is an increasing and alarming risk of mosquito-borne viral illnesses. So in Florida, Texas, for example, Zika virus, dengue virus, a virus probably most of our listeners have never heard of called Chikungunya.
Chikungunya. What does that
I
mean?
don't know, but you don't want it.
You don't want it, Tracy.
So you can't kill. What are we going to do about this? I mean, they're spraying for mosquitoes down in Florida, but you'll never wipe them all out.
That's right. Well, there are a couple of things to do. I think the most important public health maneuver is that we get rid of standing water. We teach people about mosquito precautions. So that's one thing. The next most important thing is we need a vaccine. We need a vaccine and we need an antiviral. Here at Mayo Clinic, we are working very hard on developing a vaccine. We're growing the virus in cells. We're learning how this virus acts. We're taking pieces of the virus and we're packaging it with biodegradable nanoparticles with the intent of developing a safe and effective vaccine.
Where's your money coming from?
Right now, we're doing this sort of off our own backs and with some Mayo Clinic support. We're looking to the NIH and the Department of Defense to get the kind of funding that you need to do this work right.
What if these years that it's taking to develop this, by the time you get there, it's already changed enough that it doesn't work?
It can happen.
I mean, I don't want to be Debbie Downer here,
Yeah,
but...
yeah. Or, well, Debbie Downer, let me just make a comment on that. While it is changing, all of the clades or types of this virus to date are closely enough related that we think immunity to one will give you immunity to all.
And how far are we away from that Zika vaccine?
I wish I had a crystal ball, but once we know the vaccine works in animals, then you've got a prolonged period of testing in humans to be sure it's safe. This one's a little more difficult because our primary group that we're aiming it to are women who are pregnant or about to get pregnant. So we really have to be very careful about the work to know that it's safe. It's going to be years.
You said it is relatively new in humans. Did it come from pigs? Did it come from monkeys? Where did it come from?
The ancestral virus is thought to have developed about 1900 in monkeys in Uganda. Amazing you can trace it back like that. And it wasn't until 1947 that rhesus monkey number 766 in a cage in a jungle in Uganda got infected with a virus. They were looking for yellow fever and realized this is something different. Wow. And amazingly enough, and Tom and others are familiar with a story like this, is some of those very brave researchers, in order to understand this virus, injected it into themselves.
Oh.
Amazing. Dr. Greg Poland, infectious disease specialist, immunization expert at the Mayo Clinic, Rochester, Minnesota, and Jacksonville. Well, I'm glad you're going down there because that's really where the problem is right now, isn't it?
It is.
Thanks so much for the update on the Zika virus, and best of luck in finding a vaccine. We hope you can do it.
If anybody can do it, Mayo Clinic can do it.
Exactly.